Our next speaker is Miss Ayesha Mahmud, who is who's going to be presenting endometriosis training in the UK, coming in from a trainee's perspective. She's not a trainee anymore. However, she is a very skilled, very competent gynecology consultant with specializing in endometriosis and minimal access surgery. She, apart from the surgical and clinical aspect of things, she's also got a PhD in health research and has got a postgraduate diploma in medical education. Thank you so much, Ayesha, for coming in and for presenting. Really appreciate it. The floor is yours. Thank you.
Thank you very much for that introduction. I'm going to dive right into it. Can you see my screen?
Yes.
Yes. Yes, we can.
Okay, thank you very much. So first of all, thank you very much for the invitation, Subal, and for Professor Amr for doing an excellent talk. Obviously, endometriosis, as we all know, is a huge problem and there's lots to learn. What I'm hoping to cover as part of this talk is about how, as a trainee, you can train in endometriosis, what are the obstacles, and how really can you make the best of the time that you're actually spending doing endometriosis.
Could you put it on a slideshow?
We can see your, yeah, that's brilliant. Thank you.
Thank you.
Yeah.
Sorry for that. Right. So to begin with, we know why we're training in endometriosis. It is obviously quite competitive. There is an ATSM in advanced laparoscopy offered by the RCOG, which can be very competitive to get into, and there are lots of preparation that you need to do beforehand to actually be accepted. We know endometriosis is complex, messy, we know it's prevalent everywhere, and we know that there are always limitations to the amount of therapies that we can offer. And as my predecessors in this symposia today have mentioned multiple times, it's not as simple as A is equal to B. It's usually quite a lot of knowledge of anatomy, imaging, MDT, energy devices, a lot of joint operating with colorectal, urology, but also not to forget the impact on the quality of life, especially in relation to pain management, patient psychological well-being, the fertility side of things. And of course, it's long hours, lots of commitment, focus, and lots to learn. So if this is for you, then my motto is that if you are going to be an endometriosis surgeon, it's not how you start, but really about how you finish. Having said that, there is a bit of preparation that goes into applying for these sort of posts. For example, you would need to prepare your CV for the job. You need to have research experience, ideally in the form of an MD or PhD. Then you need to be taking part in endometriosis related audits, presentations, publications, write book chapters. You could participate in RCOG learning as well. You could write chapters on how to approach endometriosis. Especially if you look at the RCOG website, there are always opportunities coming up with the e-learning team where you could get involved. Other things to consider are approaching academic colleagues who've already publishing or doing work in the field of endometriosis. It's important to engage with research societies, so become a member of the BSGE. It doesn't cost a lot as a trainee, ESGE, ISGE, there's so many of them. But the one that I found most helpful was actually the BSGE, because it's our local British one, and they offer a lot of tools that you can use to develop your CV as a budding endometriosis. There are awards that you can apply for and other things that you can do with the BSGE. Then, of course, going to meetings like the recent ACM, looking for networking opportunities, looking at what people are doing, finding opportunities to learn, train in things, and also become part of the research network is really helpful. Even if you're thinking, well, I can't take 3 years out to do a PhD, you can still recruit for studies, and that's like a very good way of getting research experience and becoming familiar with the project. And other things you can take on is a quality improvement project. As you know already, a lot of things in endometriosis are not exactly black and white. So you could do a quality improvement project on a gray area, which would obviously support your application towards these things. Other things I would say is, for example, matching the essential criteria, desirability criteria set out by the deanery. Now, the advanced lab ATSM is usually advertised at deanery level. Now, that means you can actually go to another region to train in it, but equally look at the previous applicants' application criteria. So look at what they're looking for. Most of them will commonly ask about teaching experience research. So opportunities that you could take on to develop those would be, for example, the simulation at your own unit. We know with COVID, there was a lot of money thrown into simulation training, and the BSG Rigs is also doing some. So you could become part of that, and you could be not only learning, but teaching people, and that counts. And then the RCOG newsletter, the BSG Scope newsletter is always full of opportunities where you could actually get involved. And the only thing is you have to go and look at it. So if you don't look at things, you won't get the opportunity. Other things which I found really helpful was getting a medical education degree, which gives you the opportunity to engage in clinical teaching, whether that's at undergrad or postgraduate level. And of course, taking part in your local and other deanery activities in terms of teaching. But more importantly, your ultimate goal should be that your CV should scream endometriosis. It should say, yes, I'm the person you want for this advanced lab job because I've got everything covered. You need to show that commitment through your projects. You can even take out of program experience for 3 months, go and work in an endometriosis center. Even if you're just observing, you've got a lot that you can get out of it. You can sit in the pelvic pain clinic. You can learn a lot which will contribute and strengthen your application for the job. Other things such as the GISIA certification. Now, this is a laparoscopy training program that you can do. The GISIA level 1 is very basic and level 2 is a bit more advanced. But these are the sort of certifications which say, yes, this person can do laparoscopy and is committed to it. So these are things that you can look into. But I would always say get into simulation training earlier on. Having done the advanced lab portfolio, what I can say is that the ATSM is quite intense. So if you get most of your things signed off or you get most of your experience done before you even get to ST6 level, then it's more useful. For example, if you're coming in as someone who's never done laparoscopy, you're going to struggle. The training program does say that you've got about 2 years to get up to speed with things, but for some people it does take longer, and that's not wrong. There are a lot of people who've actually done part-time training just to make sure that they've got plenty of experience before they go on to the next step. Ultimately, the deanery will decide how the job for the advanced lab sits within each deanery area. However, some hospitals will also ask you to cover obstetric on-call commitments, and more than 50% time, according to the RCOG, should be allocated to the acquisition of the ATSM requirements. Other things you need to do is the intermediate ultrasound skills in gynecological imaging. And again, I'll talk about this a bit more. Now, just to show you what the advanced lab looks like, essentially it's got 4 SIPs. You've got the advanced lab gynae surgery, holistic management, lap surgery, urological and colorectal interventions. If I show you the first 2, what this is basically telling me is that I need to know about which patients I'm actually going to work up, which ones I'm going to be taking to theater, and how I'm going to actually counsel them and give them the information they need to make that decision in terms of treatment. Obviously, this is stuff you need to learn under the supervision of your supervisor and mentor. Other things you need to cover is hormonal, non-hormonal treatments. We've heard about that earlier in today's talk, and then also about assisted conception techniques, because fertility is also an aspect. And of course, pain management, which we've also spoken about today. Next, when it comes to appropriate lap surgery for treatment of the patient, this is where you need to be able to recognize bowel bladder complications, as Professor Ahmed rightly said. You should be able to pick these up intraoperatively, but also pick them up postoperatively, and also be able to judge which patients are likely to actually have issues so that you've got a closer eye and you're watching for the signs of anything going wrong. In addition to this, you need to have advanced lap surgical skills in myomectomy, and excision of endometriomas, which again goes into benign gynae, but again, it is part of this advanced lab curriculum. Other things which are the more complex things to cover are urological procedures in laparoscopy, the colorectal procedures, and picking up the late complications of these things. As far as urological and colorectal procedures are concerned, the things you need to do is cystoscopy, ureteric catheterization, stenting, and colorectal you have to learn to do rigid sigmoidoscopy, proctoscopy, and be able to suture bowel if there is a problem. So the challenges in training at the moment are, having spoken to my colleagues who are also part of a WhatsApp Advanced Lab group, basically the issues at the moment in training are dedicated and protected theatre sessions. They feel that their time is caught between obstetric commitments and getting to theatre. But again, this is variable from unit to unit. The other issues are obviously training in MRI and ultrasound has really taken a hit during COVID times. We've got lots of sonographers who are trainee sonographers, so they don't actually have time to train other individuals. So one of the things you could do is, perhaps if you're planning to take on this ATSM, think about doing your intermediate gynae scanning before you join at ST6. Or if you are already at that point, make sure that you've got dedicated sessions, and you can also use simulation in ultrasound training to help you get there quicker and safer. Other issues at the moment are some courses can be really expensive. We recently had a course that I was looking at, which was advertised for £4,000. And obviously, even as a consultant, I don't think I can afford that. Having said that, there will be courses out there for 300, 400, and you'll have free days like today to learn a lot from our esteemed colleagues. Other things, obviously, rota shortages are going to be a problem. And the way around that is that if you have a case, you may actually have to come in on your off day, stay longer. And that's how you really get around to get the competencies you need for this. The most important success factor, I would say, is your mentor-trainee relationship. I've been fortunate enough to train with Mr. Al-Ghazavi and Mr. Mishra, who have taught me the bread and butter of everything I need to know as regards to endometriosis. However, I've also gone to other colleagues' theatres and learned so much from them. So it's about casting a wider net and making sure that you're getting as much skills as you can from everywhere. There is also an issue with academic components. Some people struggle to do the research aspect. And again, this is something you could do earlier rather than later on. The other challenges people actually have are whether their unit actually does a myomectomy. We know that because of contained morcellation issues at the moment, a lot of units have stopped doing laparoscopic myomectomies. They would only do open procedures. But like a colleague of mine does the Alexis contained system myomectomies. I went to their theatre to learn that, and these are the sort of opportunities that you can have. Having said that, I think some of the issues at the moment is that the portfolio was curriculum was made up years ago, and things are changing. Things like robotics are there, ICG is there. Procedures like rigid sigmoidoscopy are rarely done now. People are doing flexible sigmoidoscopy. There are some bowel surgeons who won't even let you do a stitch on the bowel, let alone the bladder. So I think we need to sort of change up things and move forward, but these things will obviously come from the RCOG. So I've sort of spoken about the possible solutions already, but in a nutshell, perhaps advanced lab needs to be a sub-spec training. And I think that would be the best way to give the protected training that a lot of people are struggling with. Perhaps we should encourage training passports where you can actually go to units who do the procedure that is not done that commonly in yours, so that you can see how people do things and you can become more of a holistically trained individual rather than be just one hospital trained and never grow from that. I think it's really, really important to find good trainers and mentors, and these are the people who give you the right advice, the right environment, and they will also support you when it comes to training opportunities and also fostering relationships with healthcare professionals and institutes. I think moving forward, we need to standardize training guidelines and curriculum. We need to implement an evaluation of how the advanced lab is going and how it could be made better for future generations, because essentially these are the surgeons who are going to operate on endometriosis patients for the next 20, 25 years or more. So my top tip is look towards industry. The BSGE runs the Olympus, the Ethicon, ST5 plus training programs. And this includes the cadaver courses, which are really excellent. And you get to listen to talks from Mr. Mabrook, Mr. Shaheen, and so many other gurus in the field. It is absolutely amazing. Other resources are the videos on YouTube and the webinars. For example, the European League of Endometriosis has its own channel, and they frequently put up their webinars there. Then what I've personally found really useful was having a peer support group. You can have these on Facebook, WhatsApp, but smaller groups tend to be better. You can have a couple of friends who are doing the same thing, working together, bouncing off ideas, and just really getting learning together and moving forward. Ultimately, I would say that the difficult to get sessions you need to plan ahead, like scan training, colorectal urology. There's loads of things on ELFH for colonoscopy, endoscopy basics, and pain management modules. And these are things that you could actually do before you even get into the job, which would be really useful because, again, you've shown commitment and it didn't take any time other than your own time to actually cover these things. Lastly, targeted training plans. You need to make sure you get on with the theatre team, rota. My bosses were kind enough to let me look at their waiting list and pick out the cases that I wanted to do and the ones that I needed experience in so I could plan the theatre session. And I think that was a very useful exercise because now that I'm a consultant, I know how to plan my list. I know what will take how much time. As best as I can predict, at least I'm doing that. And of course, simulation gets you there. So things like suturing, if you've got it all sorted, you will be able to do things quicker in theater. Other useful websites, I would say the Olympus Hub website is very good. They have a lab prestige program where you can enroll and they get you to mentor and do training with an endometriosis expert in Spain, Italy, across the world. So there are lots of opportunities out there which you should really look into. Um, in the end, I would say that these are the resources that I've used in my 2-3 years of learning advanced laparoscopy. My favorite ones have been the End of the Bay sessions. They do a meeting every year, and I was absolutely mind blown by how they covered the basics to the more advanced things in a session with so many things that everybody can learn from. And of course, the MIS Academy has been really useful because they have a lot of videos that you can access and you can go back to the lectures that were developed in End of the Bay. BSGE meetings particularly, and if you're looking towards the robotic side of things, then SERGs, BIARGs, these are the ones you want to look for. The World Endometriosis Society tends to run excellent conferences, which are really cheap to get to, and they are really, really useful. And as I've grown into the role that I am today, I've realized that our trainers and mentors are there for us, but also it's important for us to be open to the idea that in 10 years' time, endometriosis will be very different from what we have learned. So we need to continue to grow, continue to learn, and we need to hand the torch over to our juniors. Thank you.
Thank you so much, Aisha. Thank you. That was very comprehensive, and I think you outlined the training life of an ALAP ATSM trainee very, very eloquently. I can see that you feel the pain equally.
Yes, thank
It
you.
seems that you've had a very busy training. Is it 2 years?
Yes, because I
Well,
was part-time, that's why.
but you showed that you had the same problem that my trainee used to keen to have a complication so she can suture the bowel. Suture the bowel. I said, I'm not going to do a
I
complication.
have to say, I celebrated the day I did my bowel suturing. So
Yes, I know. I mean, no harm intended, but yes, you become so focused. I don't know whether to say fortunately or unfortunately that, you want to sort of do everything you can. And the main thought process is if I was alone in this situation, what would I do if, and
As you,
that's I
exactly,
think
as you
exactly.
said,
But
there are a few things that need to change in the modules.
hmm,
And
yes,
I support the idea of changing it to a sub-spec.
absolutely,
It's a huge mod.
it's
absolutely.
too
Huge.
much. It's a
the the
lot to do.
curriculum is equivalent to a sub-spec trainees.
Yeah.
The things that are required for us to know as advanced laparoscopists is not feasible, not doable in a 24-month course with where you've got on-call commitments.
Yeah.
Yes, absolutely.
Brilliant. Any trainees have got any questions? Nilofer, have you got any questions for Dr.
Yes.
Mahmood?
I just wanted to point it out to everybody out there, especially those who aim to take up this ATSM advanced laparoscopy. Uh, whatever has been said by Dr. Mahmood right now is very, very, very helpful because last year, she had given all these golden advice to me, and that really worked for me. And in addition, and then Subul as well. So I have to thank them both for being successful through the interviews.
We have got her here.
Absolutely.
All right. Thank you.
Thank you so much. Thank you.
Thank you very much.